Good afternoon. I think we'll get started. Thank you all for joining us today for the John Romano Clinical Rounds. I'm Sue DiGiovanni. I'm Vice Chair for Clinical Services, and I am very pleased today to introduce Dr. Emma Lowe as our guest speaker, and she will be joining us virtually. Dr. Lowe is an assistant professor of psychiatry at the Yale University School of Medicine. She actually trained at our medical school right here in 2015. And during her time there, she started the volunteer outreach group, UR Street Outreach, and that is still active today, which is wonderful. She completed her residency training at Yale University in 2019 and is currently the medical director and was also the founder of the Street Psychiatry Program at Connecticut Mental Health Center. She also serves as the co-director of the Public Psychiatry Division track within the Psychiatry Residency Program. She has really dedicated her life to working with unhoused populations and is interested in the implementation of models of care for vulnerable populations, as well as the intersection with addiction care and medical education. So looking forward to her presentation today on her work in engaging unsheltered populations in mental health and addiction care. Welcome.
Thank you so much for the kind introduction. And it is such an honor to be virtually back here at the U of R, where I did my medical school training and were some of the most important learning moments in my career, and just really excited to be here. And I'll get to some of those important moments in terms of the UR Street Outreach Program in this talk. And thank you so much for having me. I wanted to just mention a brief note is that the artwork in this presentation is all my own artwork. These are portraits of people who were experiencing homelessness at the time, from many years ago, most of them. And just wanted to mention that, since I think sometimes art has a way of shaping our impressions of people and adding a humanistic kind of tone to my talks and also to the work that we do with our patients every day. So please enjoy them. They're not current patients or anything like that. So street psychiatry, I wanted to just start by talking a little bit about street medicine. Street medicine is a growing entity and movement around the world, which is the foundation of where street psychiatry comes from. But these are some examples of where street medicine is around the world. And street medicine is the idea that we're bringing medical care out to people in the community, people who are experiencing homelessness that wouldn't otherwise have access to care on their own, and literally delivering that care on the streets. And street psychiatry, in turn, is this model of actually engaging people who are living outside, who are on the streets around their mental illness and addiction issues. And I like to talk about street psychiatry in two different senses, about kind of how we're doing what we do and where we're doing what we do. And I'll start with the where. And so where we go is literally outside. We're meeting people where they're at, very literally and figuratively. So we're going out to encampments, under bridges. In Rochester, it was often the parking garage near the train tracks, very different locations. And this is about meeting people literally where they are in their own homes, even if they are unhoused, and engaging them on whatever terms that they might be willing to talk about that day. And then the how is really this more figuratively meeting people where they're at from a non-judgmental approach, engaging with them at their level and whatever goals that they might have. It's this really radically person-centered approach where we're going out and reversing that doctor-patient relationship that normally exists in a clinic setting, where we're reversing that power, where now we're on their turf, they're on their literal territory, and engaging them at whatever point they are in the spectrum of stages of change, and engaging them on their own terms. And this is a picture of some of us doing outreach in our community in New Haven. And I like this little graffiti here, everything for everyone. And so that's sort of one of the things that we're doing out there is trying to bring uh, the mental health care and addiction care to everyone and making sure that that's accessible for all people as a human right. And street psychiatry might be a familiar concept to some people, but it might also be really, really new for some people. So just to explain sort of how it overlaps with existing models of care, all of these different models, street psychiatry, ACT or assertive community treatment, and outreach and engagement all have in common that these models are meeting people where they are at in the community, engaging people who may not readily come to a clinic setting. And there's this non-judgmental approach and a priority for case management and addressing the social determinants of health. Street psychiatry is specifically unique because we are a clinical team that goes out and engages new people every day. We're looking for people who are experiencing homelessness and evaluating them, triaging them in the field, and trying to help them connect to care if that's what they're interested in or whatever they might be interested in. And ACT teams or assertive community treatment, they're also doing outreach in the community to people who are not going to come in for regular care in a clinic setting. Those people are typically tend to have a serious mental illness requiring a certain number of hospitalizations per year to meet criteria for ACT. The people on an ACT team generally don't have to be unhoused. It could be maybe some people who are unhoused, some people who are housed, and they would go to wherever the people are at. But we're a little bit different in street psychiatry in that we're both following a caseload of people probably with serious mental illness that may or may not meet ACT criteria, but we're also seeing new people and triaging new people just through canvassing, meaning like outreach to the streets and encountering new individuals wherever we are going and taking new referrals. Outreach and engagement, on the other hand, is a non-clinical model. There's many different names for this, including street outreach, outreach and engagement. And this just means outreach workers who usually have lived experience of homelessness or mental illness or addiction, who are going out and engaging people in the community, trying to work on their housing issues, for example, or other social services, but they don't necessarily have a clinical component. And so, and they may be encountering people who may or may not have mental illness. That's not the kind of the focus. And so we're really complementary to those teams. We add a clinical expertise and can engage people engaged by the outreach and engagement teams who are non-clinical and adding this clinical component there. So a lot of our model also is really harm reduction focused, and I mean that in a few different senses. One is basic needs, and so I have on here just socks and hand warmers, and you can think of those as harm reduction items. We're trying to reduce the chance of someone getting frostbite in the winter on their hands and feet and protecting them. These also can be used as engagement items. So it's sort of, we don't start by asking people, do you have a mental illness? Do you want to talk about it? We start by offering basic needs items like these and including food and these kinds of things to make sure people understand that we're coming with some sort of thing to provide them and assist them. And only after we build that kind of foundation of trust and respect with them, then we can move on and potentially, hopefully, eventually talk about their mental health and addiction needs. But sometimes that process can take days, weeks, or even months. And then harm reduction in the addiction sense, and we're passing out supplies such as clean needles to reduce the chances of infection through HIV and hepatitis C, through dirty needles, and also fentanyl testing strips, xylazine testing strips as well, to help people inform their decisions about their use and make sure that they're using as safely as possible if they are going to use substances. We also provide Narcan. We pass it out to people. We can do that without a prescription now. And this is really important to help people understand that the overdose risk among this population, which is unfortunately very high, helping people save their own lives or save their friends' lives from an overdose. So these are some of the supplies, and I think what's more important is just the harm reduction approaches, that we're not assuming that someone is ready for an abstinence kind of direction. We're working people with whatever stage they're at, which could be actively using, and showing them that we actually really want them to continue to be alive. We want to help them protect them, help them use safely so that they can continue their lives. And hopefully that will lead to, and often does, a conversation about medications for opioid use disorder and other medication-assisted treatment. In New Haven and Connecticut, we have an unhoused population through the point in time count numbers of about 3,400 people. New Haven is a small city, about 136,000 people. About 600 people are unsheltered and unhoused, which is our target population. And I'll talk about that in a second. Unfortunately, we don't have enough shelter for people, even if they wanted shelter. There are many reasons why people won't accept shelter, including using substances, having pets, having a partner where they can't go both to the same shelter. But our shelter wait list is about 600 people long, unfortunately. And why do we focus on unsheltered, unhoused people, also referred to as street homeless or rough sleepers? These are folks that are sleeping outside, literally in a tent, in a car, on a sidewalk, without a tent, under a bridge, anywhere where there really is no heat, there's no electricity, there's not really anything to support them except what they've brought with them. And the reason why we focus on this population as opposed to the sheltered population is a lot of these unique vulnerabilities that I put here. The mortality rate is much higher among the unsheltered folks compared to sheltered counterparts, and 10 times higher than the general population. There are higher rates of mental illness and substance use disorders in the unsheltered population compared to sheltered individuals, higher chances of incarceration between these two groups, and finally, a higher healthcare spending, about 3.4 times as much spending on healthcare of the unsheltered folks compared to sheltered folks due to the ED and inpatient utilizations. And so coming to this, I think you're getting the idea of why street psychiatry would be important, but the basic idea is that there are many people on the streets with chronic and serious mental illness that face a lot of barriers to accessing care. The folks who are unhoused tend to have a lot of stigma about either seeking help themselves, but also they face stigma when they seek help in a hospital setting, in a clinic setting. Maybe they haven't showered, maybe they are in withdrawal, they're uncomfortable, they're treated poorly, they're made to wait, and they don't feel welcome, they don't feel like coming back for care. And the result of that is this kind of cycle of people not seeking care when they really should be seeking care. And we're trying to be ambassadors of the healthcare system and show people that, mental health care can be friendly and helpful for people. Some people have had really negative experiences of involuntary treatment, unfortunately, at some points in their lives, and other traumas. Other barriers include just logistical barriers, like people not having insurance or not having a phone, transportation, IDs are sometimes required for certain clinics and programs. Other requirements, like you must go to a certain number of appointments before you can see a psychiatrist, or you must go to groups, and people sometimes are not able or willing to do that. And then just daily survival needs, like I need a place to stay, I need to find food, I need to be safe. And these things take priority over going to a mental health appointment, for example, or going to a program for substance use disorders. And substance use itself, sometimes what we're often seeing is people waking up in withdrawal from either alcohol or opioids, most commonly, and seeking their first use of the day just to feel normal. And most of the time, these people that we're treating are not getting high, they're not getting a rush from their substances, they're just trying to not be sick and feel at least a little bit normal during their day. And sometimes that need and urge can take priority over actually treating that and making the next step towards getting addiction treatment. The burden of mental illness is extremely high among people experiencing homelessness. There's a lot of varying numbers, and I'll just say as a caveat, these are from systematic reviews and studies. There's also the point in time count, which I alluded to earlier, which is a nationwide count of people on one night in January where all of the unhoused individuals in the country are counted. That's not as accurate in terms of describing the population because it's run by wonderful, wonderful people, wonderful volunteers, but they're asking people sometimes for the first time, do you have a history of mental illness? And as you might imagine, people who are meeting someone for the first time might not disclose that to a volunteer who's just meeting them on the street on this one cold night, usually in the middle of the night. But these studies have shown actually much higher percentages. So while the point in time count might say about 25% to 30%, these studies are showing 2/3 of people having mental illness among people who are currently experiencing homelessness. About 2/3 also have had suicidal ideation in their lifetime, and half will have attempted suicide. Astounding numbers. About half have been victims of violence. About 40% have had child abuse themselves or witnessed it. Some of the most common diagnoses are substance use disorders, so alcohol use disorders, followed by other drug use disorders, followed by schizophrenia, major depressive disorder. You'll notice that PTSD is not on there despite a really, really high rates of trauma in our population. And what I typically see is that the substance use disorder is paired with this lifelong history of trauma. The substance is being used to treat the intolerable symptoms of trauma and just the dysphoria that people are experiencing. And so what I clinically most often see is this idea of a dual diagnosis, both a substance use disorder and major mental illness, and usually underscored by this lifelong history of trauma and oftentimes ongoing trauma while someone's still experiencing homelessness on the street. So our approaches need to be really tailored to folks with a high trauma history and serious mental illness. So a lot of times we're going out, like my friend here in this picture, and trying to engage with people that are maybe not willing to talk to us for the first time. And sometimes that means just barely being able to have a conversation. Maybe having them accept supplies from us is a big win and a big accomplishment. One of my fellow street psychiatrists always says the only goal of your meeting is to have the person consider meeting you again. And I like to remember that because in our clinic setting, oftentimes we have our own agendas, right? We have our checklist, we have our risk assessment, we have our diagnostic tools, our screenings, we have all these things to get done for the patient, for our clinic requirements for insurance. And kind of unlearning that is what I've had to do this work and to go out to the streets and really put the encounter in the assessment in the patient's hands instead of directing it myself, and reminding myself that the engagement is the whole foundation upon which any other care can be built. And so just hoping that this person is not going to be turned off by something that I do, some of my body language, some of my titles, and hoping that they're willing to have me come back. And we often ask permission to come back to make sure that people realize that we're trying to have this relationship with them on their own terms. That involves building respect and building trust. A lot of relationship building is takes a long time, takes, like I mentioned, months, even years. Sometimes that means really making sure you keep your promises. If you say you're going to bring someone a sleeping bag the next day, you have to follow through on that promise, because our folks have been disappointed by the system many times. Sometimes they've been promised housing and not gotten that, or been told things and it's not been true. So, and then lastly, just body language, like my friend's doing here, getting down to the eye level of the person and making sure that we're not towering over folks, and we're using a trauma-informed approach to care. Now I'm going to talk about just an example of all of this, because I think there's no better way than using a case to demonstrate what we're doing on the streets. And this is not his picture, but just kind of evoked him for me. So I wanted to illustrate his case with this drawing that I did. But we'll call him Poppy. This is, anonymized, but this was a elderly man from Puerto Rico, and he was chronically unhoused on the streets. In his chart, there was a history of major depressive disorder with psychotic features, bipolar disorder, alcohol use disorder, antisocial personality disorder, substance-induced mood disorder, traumatic brain injury. And as you all know, you can't really have all these diagnoses at one time. This would be really impossible, but just shows that really complex personality, really complex kind of presentation. Unfortunately, had frequented the hospital very many times. At the peak was 7 hospitalizations during that year for a mixture of psychiatric and alcohol-related reasons, alcohol withdrawal. And he had over 20 visits into the ED that year. Sometimes they were also related to falls and other kind of issues that he encountered while he was sleeping outside on the street in a bus stop. First time I met him, I was doing outreach to a soup kitchen with some of my street medicine colleagues early on in our program's development. I saw him outside the soup kitchen pulling a large suitcase, and he just was saying, "I kill everyone and I kill myself," and putting like a pistol gesture. And so obviously this is pretty concerning. At the time I was still a resident, and I was like, well, does this person need to go to the hospital? Like, what do we do here? Is this someone who's acutely suicidal and homicidal. And then he just walked away. And so I'm like outside in the public, I can't really chase this person. There's no, what am I going to do? Like following this guy around with his suitcase and his threats and sort of like prickly, hostile personality at first. And so, but this was a pivotal moment, actually, I would later come to learn because this was just someone that was clearly our target population of someone that was not being served well by the system, who was utilizing the hospital frequently, that really just had so much trauma that led to his presentation. So our first move, instead of hospitalizing him against his will, was to engage him. This was difficult to sort of swallow, I think, and certainly other people would make a different choice in this kind of situation. But we were able to understand his threats later as this need to be bigger than other people, this need to show his power, and of course that was representing his sort of helplessness and feeling small inside and feeling like he needed to sort of show power to protect himself from being victimized himself. So we later were able to understand that better and spent months and months engaging him, just offering him supplies, sort of tolerating some hostility, some inappropriateness. But we just kept coming back to him, kept seeing him on the public green and working with him whenever he had needs. We would try to address them. And meanwhile, he was banned from almost every program we knew about because of threats and behaviors that were not accepted in those places that were otherwise meant for people who are unhoused. Then one day we were working with him and he's like, I need my diabetes medication. We were like, wow, like we can actually help with that. And so we were able to figure out what it was, get it refilled. We walked him to the pharmacy down the street. Luckily we did because his insurance wasn't on file. So he started getting into a verbal altercation with the pharmacist who didn't have his Medicare number. And we were able to get that straightened out because we were there with him. And then he forever remembered that we were able to help him get his metformin. And of course, we helped him get his other medications, which included gabapentin for his alcohol use disorder, his Depakote for this unspecified kind of mood lability, and his other medications as well for his medical needs. This was through eliminating all these barriers for him by literally going with him and witnessing what his reality was and understanding that every step of the way, you need to think through what someone on the street is going to be able to do, rather than just thinking like, oh, I prescribed them medication, they're going to pick it up and take that medication. And other times we would bring treatment to him. For example, we would make him appointments with his primary care. We would offer to like pick him up and drive him there. We brought a nurse to give him the COVID vaccine at his own house. Unfortunately, he refused, but we still tried to make sure that the treatment was as accessible as possible for him. And then the third phase was really this housing phase, which was, I think, just a miracle. He built a relationship with this wonderful, wonderful case manager as part of our team, Teresa, who managed to get him an apartment. And this was huge for him. This was also during COVID. So being able to see him inside and live in this apartment was just really amazing. But of course, as many of you probably know, that's not the end of the story. He lost this apartment very quickly because it wasn't really in a good location. He didn't have the supports that he needed. So we were able to convince him that he would benefit from a conservator. And in different states, there's different terms for these, but basically guardianship to help manage his money, help take care of him and make sure that he's paying his rent, his housing is in place. And he was willing to do that, I think, because of our long-term relationship and believe that this was in his best interest. So we did a hearing and he agreed to have a conservator, even though this was sort of the involuntary category. We still went forward with the conservatorship, and he agreed to it. So we consider it kind of voluntary. This allowed him to get a new unit for housing, stay in that unit, and remain there actually until he later passed away. But just to mention, there's a lot of recidivism. Probably, I think 100% of our patients that get housing lose that housing due to the same reasons that were there before that led to them losing their housing in the first place. And so there's a lot of additional support that's needed to make sure people don't lose their housing. And so I mentioned this, the therapeutic alliance was really the most important part of all of this. He was able to maintain housing. I think what's so remarkable about this case is that his health measures improved and, in fact, normalized after he got housed. And we thought it was because maybe he's taking all his meds, and that's great. He had actually stopped all his meds. He wasn't taking them anyway, even though he had been so like insistent that he needed them. That wasn't the reason. He just was more stable. He was drinking less just by the happenstance of being in an apartment, not being in an environment that was kind of forcing him to want to drink all the time, and the other people that were sort of triggering that. And so it begs the question of what really it was the diagnosis. He no longer had this kind of a portrayal of scariness to other people. He wasn't making suicidal and homicidal threats all the time. He was just living his life in his apartment, and we were able to sort of support that. And then just to like drive home this point, this is a graph showing his hospital utilization, the ED visits, and when he was housed, clearly you can see the remarkable drop in the ED visits and hospitalizations from the point of when he was homeless and to afterwards when he became housed. So not taking credit for that drop, but just saying that I think it's been said many times that housing first is really important. Housing is healthcare, and this is just a clear example of that. And so now I wanted to just shift gears a little bit to talk about how I got here and my pathway, and I'll talk a little bit about our New Haven program a little bit more. But so I've been interested in homelessness for a long time, and when I was in college, I went to Haverford College. I was part of this group called Street Outreach, happens to be the same name, and we would go to Center City, Philadelphia, and bring soup and sandwiches to people. At that time, I was like, wow, we're making a difference. We're volunteering, we're like, feeding people. And I, of course, like later realized that it wasn't really about the soup and sandwiches. It was more about the conversation with people that would otherwise, be ignored, and not even, people wouldn't even make eye contact with them during their days. And so I built relationships with a lot of these folks on the street. And I, at the time, was doing actually my studies in fine arts. So I did a fine arts major while doing pre-med requirements. These are some of the portraits from that senior thesis work that I did. And these are our portraits of the folks that I met in Philadelphia and also from Pittsburgh, of folks that were living outside and were gracious enough to allow me to draw and paint them on the streets. But that's where it all started. I was really interested in this intersection between the arts and humanities and medicine and social justice. I then went to Pittsburgh, where this is a photo in the middle here of Dr. Jim Withers, who was considered the founder of the street medicine movement. He started this program, Operation Safety Net, in Pittsburgh, and I heard him speak at Haverford, where I was in college. And I was like, this is what I want to do. So I followed him to Pittsburgh, went there volunteering for my winter break, spring break, and then summer break. And then after I graduated college, I was like, how can I get a job with this place? So luckily I found an AmeriCorps position with them and was able to learn all these amazing things about street medicine, about serious mental illness, about housing and case management and the difference that it can make, and about believing in the folks that are out on the street and believing that there is something better for them. And I think that was what that really showed me. And so I was taking this experience with me into my next phase, which this was actually Kolkata, India. So I did a 6-month, what was called a street medicine fellowship, although not a fellowship in the medical sense, but more of an internship. And I worked with Dr. Jack Prager, pictured here, on his street medicine program, where he was delivering street medicine to the people of Kolkata in the slums and the street districts. As you might know, Kolkata has an enormous, probably uncountable street population. And the needs of this group were really dire. And so I was seeing things like leprosy, like multi-drug resistant tuberculosis, vitamin D deficiency leading to rickets, vitamin A deficiency, other kind of more rare infectious diseases. And so this was just really pivotal experience, learning about their program and how they do street medicine on a population level in a city as large as Kolkata with such extreme disparities in poverty. This was just really, really fascinating for me, and tried to give back to them, but mostly they gave me such an amazing experience. These are just some photos of some of the impressive care that they were able to give out of this back of an ambulance. And then Rochester, just such a full circle moment for me. Rochester was where I thankfully came to medical school, because this school was so supportive of developing a street outreach program. And when I came here, I just wanted to figure out how could I continue to do street medicine during my medical school days. And I linked up with some other students that were interested, and found what I've learned in my street medicine kind of tenure, I guess, is that you really need someone with lived experience, and you need that person to help guide you. It can't be just, of course, me as a medical student going out to the streets and finding people. That's not really gonna make a difference. But so we were able to find several people with lived experience that were willing to take us and guide us into the community and help understand better what the needs were. Some of those people were Hubert and Steve. I'll just mention them. They're really, really awesome. I hope they're doing really well. We were recruited in attending Dr. Lois Van Tall, who is a family physician in Rochester, and that was kind of our initial street medicine team. We based our model off of the program in Pittsburgh, but of course we're student-led and couldn't practice in the same way that Dr. Withers could practice, but we're oftentimes just doing that relationship building, that foundational work of engaging with people who are living outside and may think nothing of their healthcare in that moment, and trying to help them maybe see that someone cares about them and see that there is a future for them, and might even involve housing. This During the time that I was running this program, there were several people that actually were able to enter housing, and that was just so remarkable to see, and seeing, the system kind of helping them eventually get to what their goals were. And I remember working with some particular folks by the train tracks that we worked for probably like a couple years to try to get them to come to the clinic. And this was the Unity Health Reach Healthcare for the Homeless clinic that I was actually doing my primary care rotation in at the time. And we got one of our guys to come in who had been just outside, for many, many years, not able to consider himself in his health. And we were able to bring him in ourselves. And it was just really exciting, really amazing moment. And of course, there was more to that story. He needed a lot of specialty care upon diagnosis of many other things. And it was a really important learning case for me that a lot of even bringing someone to a health appointment doesn't mean that they're going to have wraparound primary care. That is just the beginning. And so we tried to work with him on getting his subspecialty appointments and all of that. But so many cases like that informed kind of like why I was doing medicine at all, and really kept me going and kept me motivated during some of the most difficult times during medical school. And I'm so happy that this program has actually continued. And at the time, Adrienne Morgan was just so supportive of us as a student-run group, and was always the one to say, yes, that you can do this, and the school supports you. And so I'm just very grateful for her. And then during my medical school times, I of course applied for residency, but I was someone that didn't really know what I wanted to do. I thought I wanted to do everything, like family medicine, and being, skilled in everything so that I could do the most benefit for people on the streets. But what I realized during this time and during my time in Rochester was that I really formed bonds with people who had serious mental illness, and didn't really understand it at the time, not having a psychiatric background before that, and not really realizing why I was kind of attracted to working with those folks and why everyone else wasn't. And it was just curious to me how, and looking back, of course, made sense why I was always attracted to working with the people with schizophrenia and other serious mental illness and personality disorders that were really the ones that would potentially be the most hated by the hospital and who are the most socially complex and difficult. And those are the people that I connected with and who still, I remember them and their stories today. And gives me hope for why I'm doing this work. So I realized that psychiatry was the way that I would make the best difference and working with people with serious mental illness who are unhoused on the street, and that there wasn't actually a big group of providers actually providing that service. It was mostly primary care people doing street medicine. And so there's this really important gap to fill. I did my residency at Yale here in New Haven, and this is a picture of some of our team members, James, myself, then Eileen, one of our residents, Nicole, and Dr. Fabiola Arbella Cruz, another psychiatrist. And we also have Teresa, who's not pictured here, our recovery coach who has lived experience. And so I came to New Haven wondering how I could get involved with street psychiatry, and there wasn't a program yet, but I looked into sort of what already exists and is this a need that the community has. Found out that there's a street medicine team, so was able to partner with them. They're run out of an FQHC. Was able to do outreach with that team, including Phil Costello, who's one of the main APRNs with that team. And of course, found out that there was a need, and they were doing the most basic mental health care from a primary care scope, but really needed some expertise in engaging some of those folks with serious mental illness and who really needed more of a comprehensive kind of diagnostic and treatment approach from the street psychiatry perspective. So this is just a little graphic showing some of the resources that existed, the red being the Cornell Scott Street Medicine team, and there was a van also associated with Yale. There was a mobile crisis team, but didn't do outreach and engagement work. Then we had the outreach and engagement folks that did case management and housing and were connected through these other homelessness networks, but they didn't have a psychiatric or clinical component either. And so that's where CMHC street psychiatry fit into this network. And I think oftentimes is the case in communities that have this, is that there's this network and partnership between different entities providing some of these essential services, being housing, psychiatry, and medical care. This is Phil Costello, the APRN I mentioned with street medicine team, and myself, and then Claudette, who's one of the amazing case managers with lived experience herself. So this is just to talk briefly about our foundation. These are some pictures of us doing outreach earlier in our foundation. This is on the New Haven Green, where we also do outreach, but also underneath bridges and encampments. And I think what's important just to note about this is that we were doing outreach from the very beginning, not just writing protocols, like creating a way on paper for us to do this. We were going out to the street to help inform our later foundation and full program that later launched 2 years later. And this is a timeline, and this is in one of our papers, but I think just to drive home the point that the street outreach was happening from the very beginning in this top sort of red segment. And meanwhile, we were meeting with other street medicine organizations, both locally and nationally, to sort of find out what's the best model of care for this type of program to launch. Particularly, we used Janian, which is a street psychiatry program in New York City. They came and talked with us more than once to try to inform our administration and multiple stakeholders that were involved in this program being founded. Meanwhile, we were also doing a lot of educational work where I was able to do this officially through the residency program. I was still a resident at this time, because I was able to make it a approved resident elective, and then was able to do it as a public psychiatry fellow during my PGY 4 year as it was offered. We later, I think I have it on this. Oh yeah, on the green flag is this pivotal event in 2018, which was this overdose event in New Haven, and about 100 or more people took this really potent form of K2, which is synthetic cannabinoids, and that caused these like severe overdoses, not like an opioid overdose, but brought people to the hospital with seizures and loss of consciousness. And that was really the catalyst for our program being funded later, and was very quickly led to us hiring a program manager, recovery coach, clinical social worker, and then myself as the physician. And we were able to officially launch before even a year had passed since that critical event. Um, the These are some of the model programs that we used around the country, particularly Janian, but also programs in Atlanta, Providence, uh, and at Vanderbilt, Nashville. Some of the stakeholders that were involved, not going to get into the specifics, but we were involving the police, the mayor, the other housing services, and the street medicine program to sort of make sure every position was in agreement. And fortunately, there was a lot of support for this, especially after this major event on the green. This is just a photo from the news of that event, and I just shined this really big, unfortunate spotlight on our city, and it was right in front of Yale, right in front of City Hall, and the state, I think, took notice of this and saw our work that we were doing in street psychiatry and said, this is a program that can address these overdoses, can address homelessness, can address addiction. And that's what we did. So we were able to get funding through an opioid grant that year, which then was absorbed into the state budget. And now we're state funded through the Department of Mental Health and Addiction Services. And then lastly, our program implementation, a lot of just logistical issues, adding ourselves to the medical record, some of our activities, which is always a moving target, but we try to be consistent. So like every week we go to the same places. This is our staffing. I kind of mentioned this already, but multidisciplinary, and certainly rely on that network of people I mentioned earlier to make sure we're providing services and have a big enough reach with our small team. This is what we do in the community. We really start with a foundation of trust building. Sometimes that leads into conversations about the social determinants of health, referring people for case management, documenting them for housing. People have to have a disability here to qualify for the most supportive housing, and so we can do those evaluations for people. We can do addiction treatment. We can start with motivational interviewing. We have a recovery coach to work with folks on their recovery from addiction. We do the harm reduction supplies and everything that I mentioned. And we can provide formal treatment as well. Sometimes that looks like actually connecting people with existing services. We can do psychotherapy, both individual and group, always out in the community where people can most easily access us. We do medication management, which looks like not necessarily passing out pills, but writing a prescription electronically to a pharmacy, which we then pick up and give to the person using their usually Medicaid or Medicare insurance to cover that. We sometimes do emergency triages, but that's actually kind of rare. We do med consultations for the street medicine team, meaning they're managing someone on the street who has a medical issue. And of course, sometimes that brings up some psychiatric issues too. And then we can engage other patients from our clinic, CMHC, that have not yet engaged or are unhoused, and can help them maybe get back engaged with their treaters that are clinic-based. These are some of our numbers. I won't dwell on these, but just showing our growth in the last few years. We've nearly surpassed 1,000 clients now that we've served. We've given out over 150 Narcan kits. About almost half of our enrolled patients are now housed. That actually has gone up in the last week, which is really awesome. And then many other people have vouchers that are waiting to be housed. And so we try to create this pipeline of services, bringing those services to people and making sure that our care isn't just the psychiatric care, but also the housing and other things that are needed to support the person. Unfortunately, a lot of people have passed away. Overdose is the most common cause of death in the unhealthy population, and most of these cases of deaths have been related to overdose. And so we really try to combat that with offering Narcan, offering medication for opioid use disorder. But unfortunately, that's not enough for everybody. Um, I won't go into this too much, but just the point of this graph is just to show that a lot of our work is actually engagement, the big gray area. And we do a lot of other work that I mentioned just now as well, but we're really an engagement team. So some of the best people, the best patients that we like want to have referred to us are the most difficult, most complex ones that are not going to get care somewhere else. And we can kind of move them along the spectrum from engagement to like maybe social services to formal treatment if they're willing. These are some of our locations that we work. Most of the time it's outdoors or in a soup kitchen. So just to give you that picture of we really are out in the community most of the time, literally on the street doing our services. We're capturing our unsheltered population where most of the people we serve are actually unsheltered. And some of our challenges, a lot of times these are kind of patient level, but also systems level barriers. This is a picture of myself and our LCSW at an encampment clearing, which is something that's fortunately taken hold across the country as many aggressive policies have pushed for this, clearing people's encampments and moving them to unclear places. But this was a patient that the city asked for our help, and we were debated whether we would help this person at the encampment clearing, as you know, we didn't want to be seen as supporting the city in enacting these sweeps. However, we did go to assist the patient and help him organize his belongings and helped him. He had quite a lot of belongings. This was at a school, and so it was a kind of high priority for them to clear. And they wouldn't give us a place where he could go. They just said he can't be here. So we moved all of his belongings. Took probably like 3 hours. We moved all of his belongings to the other side of the fence. And we're kind of like, there. He's not at the school anymore. Unfortunately, that wasn't really what they wanted. So they did clear all of these belongings again the next week. But just some of the kind of heartbreak that we witness and go along with our patients by just being with them and experiencing what they go through from this like systemic oppression. And this person was actually later housed and didn't actually exhibit any further signs of hoarding disorder or mental illness once he was housed. Meanwhile, the city had actually asked us to pay for him to make their job easier of doing the encampment sweep. So some of these challenging issues. Other things are just like working with someone for months and years can feel really difficult, and some people are still pre-contemplative after years of working with them. Sometimes it's hard to follow up with people. We working with a lot of people that have no phone, so we have to know where to find them, if they're not where they're supposed to be or where they're living, figuring out like alternative ways and being reliable in a certain location where they might be able to find us. Drug supply, I mentioned overdose, fentanyl and xylazine being highly responsible these days, unfortunately. And our drug supply has very high rates of that prevalence. And then systems-wide, I think I mentioned housing as healthcare. That's still not enough, though. Housing First has been proven time and time again to be important for people's wellness and in ending homelessness. However, in reality, what that looks like on a day-to-day basis is not necessarily getting someone into an apartment and just leaving them there forever. We are reliant on a lot of external factors. Someone might have the funding and subsidy for an apartment, but the landlord does a background check and says, no way, you're not getting this housing. They're stuck with this subsidy that they can't use most places. Skyrocketing rent prices, the subsidies can't keep up with the high rates of rent increases. And so a lot of people are not able to use those vouchers on most apartments. And then like the recidivism to homelessness is really high because the supportive housing is still challenging for people to access and in reality not actually fully appreciative of the many complex factors that people with serious mental illness have. Other things, and then I'll try to wrap it up for questions, but sustainability, we're really thankful that we're state funded through the Department of Mental Health in Connecticut. But we don't really bill hardly ever. We can't bill most of the time because of insurance barriers to the physical location and the nature of the complexity. Sometimes if we're passing out socks or just doing engagement, that's not really a billable encounter in the first place. And then trying to figure out what are we measuring, how do we prove to like an entity that we are doing success? And a lot of those success measures are actually person led and person centered. And how do we prove that we're actually making a difference besides saying like, oh, we helped house these many people. And then I mentioned the encampment clearings. It just makes it harder to find people, harder to connect. Evidence has shown that increase in overdose deaths, increase in dropping from treatment, and other negative outcomes, but yet encampment clearings are still really prominent. This is just a picture of an encampment that was cleared and the sign from the Connecticut Department of Transportation. But what you don't see is that in this corner, there are two people living there in this debris. And it took us a long time to realize this because we thought the encampment was cleared and this was just like a pile of blankets. And we realized that this was two people living on the coldest day that year, living outside with nothing because all of their belongings have been cleared. So just a sobering kind of moment for us, and just feeling like we're dealing with this systemic oppression and up against these factors of our state and other entities just making our patients' lives worse, and trying to fight for them and advocate for them nonetheless. And lastly, I think the most important thing we do is believing in people. We're here for the people that are the highest utilizers, the most difficult, the ones that won't present it ever for care, the ones that have leg wounds that are not, they're never going to accept antibiotics, that are using every day like the highest amounts you can imagine. And we believe that they can get better. And I think that's just the most important thing, is we're believing in people that have their family, the school system, the criminal justice system, the hospital system has stopped believing them a long time ago, and worse, has even harmed them. And we are coming at this work from a place of, we are holding this person in front of us as there is hope for you and you can live a better life. And we hope that they see that, that we truly come from that place. And fortunately, we are lucky to have been doing this long enough to see these success stories of people achieving what they wanted, getting into housing when we never thought that was possible. So thank you so much, and I'll take questions.
A couple of questions, at least from our virtual audience. One is from Dr. Whitting, who wanted to thank you for the wonderful overview of street psychiatry and for sharing your impressive career journey. She commented that those of us working with patients with severe mental illness in inpatient settings are often trying to apply similar harm reduction principles, though they can sometimes feel at odds with health system rules, and we always need to balance acute staff safety concerns. So interested in your thoughts on how lessons from street psychiatry might translate to the inpatient medical and psychiatric environment in particular.
That's such a great question. And we interface all the time with the inpatient psychiatry and medical units here. I think what is really important is kind of taking a holistic approach, and of course an acute inpatient psychiatric hospitalization might not be able to fix everything for the person, and certainly with some of the other pressures of billing and everything, like our lengths of stay can't be super long. We can't get someone housing in a week or two. But I think what would be great is to see more of the process getting started when it's an opportunity for a lot of connections to be made. For example, when someone's hospitalized, they might be able to meet an outreach worker. They might be able to be assigned a case manager, and that person could make that connection in the hospital to start that process towards housing. They might be able to meet a team like ours to start, that process of working on treatment. And when you're able to make great progress with maybe starting someone on an antipsychotic or medication for opioid use disorder, then following that, the outpatient team, like a street psychiatry team, could make sure to continue that treatment so that it's not just kind of lost when the person isn't able to follow up. So those are just some of the examples of how it can be a really great, important time of connection and an opportunity.
Great, thank you. Another question, given the unique challenges of street psychiatry where caregivers may often face patient rejection and aggression, disengagement, and a profound sense of hopelessness and despair that may affect patients and clinicians alike, what strategies or practices do you recommend for maintaining the desire to continue engaging with patients over the long haul?
Yeah, so I think there are maybe two things. I guess is like the difficulty of the family members, and sometimes we meet people with no family at all, but sometimes people do have family that have been alienated for a variety of reasons. Sometimes the very behaviors that have led to their being unhoused in the first place. And I think what keeps us going is that a lot of times we actually are like not that likely to be the recipients of anger and high high affects because we're going in with an approach that is sort of disarming ourselves and coming into an encounter with this sense of humility. If someone is saying like I don't want to talk to you today, we're like, okay, that's okay. Can we come back tomorrow? And they're like, no. And then we're like, okay, like we'll try next week. And then maybe we try next week. And then they're like, oh, like I just need a cup of coffee. Like, can you get me a cup? So we get them a cup of coffee. And they might be really hostile in the meantime, but we're with them during that hostility and showing them that it's okay. We're here for you, whether you're welcoming to us or not. And if you say no, we're going to back off. But what are your needs and how can we be there for you? And sometimes that process just it takes a long time because that person has lost trust in a lot of their loved ones and the system. And we're trying to show them that we're actually going to be there for them and in it with them for the long haul. And sometimes that looks like a cup of coffee. Sometimes it looks like socks. Sometimes it looks like letting them borrow my cell phone. Simple gestures like that are just sort of what a human to human interaction can be, but can really be meaningful for someone who has been rejected repeatedly by many other people. And no wonder that they're feeling hostile and feeling mistrusting of others. So.
Thank you. We have another question for Dr. Van Orden, who is part of a suicide prevention research group. You mentioned that high prevalence of suicide ideation. Do you think about the feeling of not belonging anywhere as a driver of suicide risk and poor health in this group? How does street psychiatry address this? Also, she wanted to mention you seem like an amazing doctor and human, and thanks for spending time with us. I think we can all agree on that.
Oh, thank you so much. Yeah, we do end up encountering a lot of people with, anything from passive suicidal ideation to active suicidal thoughts and even plans. And a lot of times we're doing these kind of complex assessments in a non-traditional setting. And I think that's one of the things I wanted to point out is, I guess, doing a risk assessment for someone that's not come into the ED, that's, not coming into a clinic, it can take a little bit more of a strategy where I can't ask as like such direct questions, but I've come up with a vocabulary of like how to ask people about their suicidal thoughts and like figuring out what will make me comfortable with letting them leave in that moment. And a lot of times what ends up happening is like they have this really serious suffering that they're making available to me to understand and witness, and then trusting me to receive some of this really, really difficult content, which can be suicidal ideation and even plans. But oftentimes we're able to work together and figure out the next step, which might be like, oh, what's making them so hopeless is that like no one's ever listened to them, or what's making them so hopeless is that like every chance that they've had to like secure housing has failed, or like we're really digging deep and trying to understand what's going on. And sometimes, like very occasionally, we have to send someone to the hospital, but we really try to avoid doing that unless it's in the person's like interest or it's the person's voluntary goal. But we're really trying to think about suicidal ideation in the long term, if that makes sense, rather than in just that moment, and trying to figure out how can we ally with this person to understand what's going on and to help them the best we can, whether it's doing individual therapy, sort of doing really frequent check-ins, or even prescribing SSRIs and other antidepressants on the street, which we also do, and just doing that kind of risk assessment more in a longitudinal way.
Thank you so much. Unfortunately, we are running out of time, so I wanted to thank you again for sharing the amazing work that you're doing. And hopefully we can have you back another time to hear more about some follow-up on some of the work. Thank you so much, Dr. Lowe.
Thank you so much. It's an honor.